afternoon, and welcome to the fourth annual Victor J. Zhao Distinguished Lecture in Global Health. My name is Kulani Abebe, and I'm a second-year master's student in the Duke Global Health Program. I joined the program after serving in Peace Corps, Namibia, where my passion for global health outcomes in sub-Saharan Africa were solidified. Now, during my thesis work with Dr. Charles Nunn, I investigate the environmental factors that affect lung and heart health in the Madagascar population. My thesis and extracurricular activities were made possible by DGHI's unique program, which allows students like myself to explore global health in an interdisciplinary manner. I'm grateful to be a part of this community, and I'm honored to represent DGHI in welcoming you to this event. As we begin, I would like to acknowledge Dr. Victor Zhao, former Chancellor of Health Affairs at Duke and the current president of the National Academy of Medicine, for whom this annual event is named after. Dr. Zhao co-founded DGHI in 2006, and under his leadership and guidance, the Institute recruited its inaugural director and started to grow to the program we know today. 4 years ago, DGHI launched this annual lecture with the support of Dr. Zhao and his wife, Ruth, who envisioned a forum where the Duke community would hear from leading experts in the global health field. On behalf of all of DGHI, I would like to acknowledge the Zhaos who are joining us today and extend our thanks for making this event possible. In today's program, we'll be hearing from Dr. Anthony Fauci. Dr. Fauci is the director of the National Institute of Allergy and Infectious Diseases and is the chief medical advisor to the president, where he has played a major role in guiding the nation's response to COVID-19. Dr. Fauci was one of the principal architects for the President's Emergency Plan for AIDS Relief, otherwise known as PEPFAR, which has saved millions of lives. He has also made significant contributions in research as one of the world's most cited biomedical scientists. Dr. Fauci, welcome to Duke. We are also thrilled to welcome Mr. David Rubenstein, who will interview Dr. Fauci. Mr. Rubenstein is a former Blue Devil who graduated magna cum laude from Duke. He is the co-founder and co-chairman of the Carlyle Group and the former chairman of the Duke Board of Trustees. Currently, Mr. Rubenstein chairs the boards of trustees of the John F. Kennedy Center for the Performing Arts and the Council on Foreign Relations. And he is involved with many other philanthropic, civic, and cultural organizations. He is also the host of the David Rubenstein Show, peer-to-peer conversations on Bloomberg TV and PBS. Welcome back to Duke, Mr. Rubenstein.
Thank you very much. And thank you very much. Go ahead.
Yeah, so now without further ado, I'll turn this over to Mr. Rubenstein and Dr. Fauci.
Thank you very much. And Tony, thank you very much for giving us your time. I should add that you also are a recipient of the Presidential Medal of Freedom, the highest honor, civilian honor our country can give. And you also are the recipient of a 1995 honorary degree from Duke. And I know that since you received that honorary degree, your career took off. So I assume you attribute it to Duke mostly, right? Your career success.
Totally, completely.
Right. So it was reported that around Christmas time, you visited the North Pole to vaccinate Santa Claus. How did that go? And did he have any side effects?
Absolutely not. He a sore arm a little bit, but other than that, he was fine, actually. So,
okay.
So we had a safe delivery of presents to the children over Christmas.
Okay, and the second shot is going to be delivered by Mrs. Claus, or who's going to give that shot?
Actually, we already gave him the second shot because it's been well over a month, and the interval between prime and boost was 28 days. I gave him the Moderna vaccine.
Okay, so let me ask you, is the worst over yet in this pandemic? I mean, is it going to get worse than it is now, or is it really, we've seen the worst?
It is, David, it really is tough to definitively predict that. Right now, fortunately, we're seeing a rather significant downturn in the number of daily infections. We're for the first time in quite a while below 100,000 new infections per day. There was a time back in November, December, and early January when it was awful. We were getting between 300,000 and 400,000 new infections a day and up to 4,000 deaths. That has turned around. Right now, if we continue that momentum down, double down on the public health measures, such as the typical simple things we talk about, the wearing of masks, the physical distancing, the avoiding congregate settings, and we roll out vaccine, particularly with the increased doses that will be available as we go into March and April, we could see the fact that the worst is behind us. But we have a challenge of variants or mutants that have now entered into the country, particularly the one that is dominant in the United Kingdom, has the capability of transmitting more efficiently from person to person. Thank goodness the vaccine that we are distributing currently is quite effective against that particular mutant. There are other mutants, such as ones that are dominating in South Africa, that actually are a little bit more formidable than that. So we're keeping an eye on that. Short answer to your question, David, is that it is conceivable that we are turning the corner on this, but we've been fooled before with different surges that came back. If you look at the pattern of the last year and a couple of months, there were times when we thought things were getting under control and then it exploded again. So although we are going in the right direction, we've got to keep our foot on the pedal with regard to public health measures.
Okay, the people that develop the vaccines, it deserves a Nobel Prize because typically it takes 4 to 7 years to develop a vaccine. This was done in less than a year, but not enough vaccines were produced or manufactured. Was there a reason why more were not manufactured early on and are more being manufactured now at a record number so that we can actually get vaccinated more quickly?
Well, David, what happened is that contractual arrangements were made with a variety of companies, even to get some redundancy in that. So we would actually have contracted for more than we would actually need to vaccinate everybody in the country. The issue is it takes time to get them actually produced. So right now, the production from Moderna and Pfizer are going as quickly as we possibly can. And so although you started off slow with a small to modest amount available at the end of December, the beginning of January, as we get into March and April, that will accelerate. Right now, to be quite honest, and it's unfortunate, the demand is far greater than the supply. That's really the stumbling block that we have right now, but that should improve as we enter into the subsequent months.
Now, right now we have Johnson & Johnson and Pfizer approved. Do you expect that others will be approved soon?
Nope, we have Pfizer and Moderna.
Right, I'm sorry.
The data from J&J is right now being examined by the FDA, and they will meet with their advisory board probably in a couple of weeks. And that's when the decision is made as to whether to grant an emergency use authorization. I hope that with the data that will be presented, that decision will be made, because that would put yet again an additional vaccine into the mix, which would be very important in increasing our capability to vaccinate people.
Now, the data upon which the two that have been approved for emergency use authorization was showing roughly 95% efficiency. Is that right? Effectiveness?
That is correct. The primary endpoint was the prevention of symptomatic disease. And the Moderna and Pfizer each had about a 94 to 95% efficacy in that regard.
Now, have you been vaccinated yet?
I have, David, I have.
And did you say which one you wanted? I mean, can you pick which one you want when you're the head of the infectious disease division?
I didn't have a choice. I used what was available to me here at NIH. It happened to be the Moderna product, but if the Pfizer product would have been available before then, I would have gladly taken that. There really isn't much difference at all between the two.
Why does somebody need a second shot with those two that have been authorized so far?
Well, from the clinical trials and the data and the science and the evidence that we have, if you give a prime about halfway through the cycle, 14 days, you get a certain level of protective antibody. We're not sure of the durability, but the boost increases that level tenfold. So there's a dramatic difference between the level of neutralizing antibodies following the boost compared to if you just gave one dose.
And with respect to the boost, some people have had side effects after the second shot that are fairly significant. Is that something to worry about if somebody's going to get it? What kind of side effects should they anticipate? Did you have any side effects?
I did. After the prime, my arm at the injection site ached a bit. The following day, it ached less. And then by the evening of the following day, it was gone. I didn't have any systemic symptoms. That was a bit different with the boost, because following the boost, I had the same ache in the injection site in the arm. That evening, I started to feel rather fatigued and a little achy. When I woke up in the morning, I felt a little chilly. I did not have a fever, but I was quite fatigued for a few hours. By the time I got to the evening of the day after the vaccination, I was back to normal. But I did get some body aches and some fatigue and a little chilly feeling.
Now, the Johnson & Johnson vaccine does not require a boost. Is that correct?
That is correct.
So does that make it better or better to get because it's only one shot, or do you have no side effects there?
It's more convenient in the sense that it is a single shot. It does not have as strict cold chain requirements. So you could keep it in a refrigerator instead of the minus 70 to 90 that you have to keep the other, particularly the Pfizer product under. The point efficacy, David, is about 72%, not quite as high as the 94 to 95% of Moderna and Pfizer. However, when you look at its ability to protect against severe disease, it is very, very good. I mean, people just don't require hospitalizations, nor do they die. So it doesn't have the mild to moderate efficacy against mild to moderate disease, but it is quite good against severe disease.
So in the early days of the virus, the pandemic in the United States, people that got the virus went to the hospital very often, and many of them were put on ventilators, and many of them did not survive. Do we have a better ability to treat people today because of knowledge we have if they go to the hospital with this virus?
The answer is yes. We've gotten, in addition to certain interventions, like realizing that in people who are on ventilators or are requiring high flow oxygen, a simple drug like dexamethasone, if given to individuals 6 milligrams for 10 days, those individuals have a significant diminution in the 28-day mortality. A number of other drugs have received emergency use authorization, such as certain monoclonal antibodies, convalescent plasma, and a few other drugs. So the bottom line answer to your question, David, is that not only are we better off in treating people because we have more experience in the general clinical care of people with advanced disease, but we do have interventions that have been proven by clinical trial that in fact are beneficial to people, particularly those with advanced disease.
Now, if you get the disease, this hydroxychloroquine, is that a wonder drug? Do you highly recommend that?
No, I don't, David. In fact, it is of no benefit.
What is the drug that President or therapeutic that President Trump got when he went to the hospital at Walter Reed?
He got a monoclonal antibody, and I believe remdesivir also. He did very well. Whether or not it was due to the monoclonal antibody that he was infused with, since it's only a single case, it's very difficult to tell whether he would have gotten better anyway. But he did get a monoclonal antibody, and I believe also remdesivir, if I'm not mistaken.
Now, if you get if you're vaccinated, can you say I don't need to wear a mask anymore?
No, that's not the case, because the primary endpoint for the vaccines that we're using is the prevention of clinically recognizable disease, namely symptomatic disease. So it is conceivable, in fact, maybe likely, that you could, because you're vaccinated, get infected, but be protected from getting symptoms because you were vaccinated, and yet the virus would still be present in your nasopharynx. And if that being the case, you don't want to infect other people inadvertently, which is a reason to continue to wear a mask despite the fact that you've been vaccinated.
Now, for those people that have had this disease, and my daughter and my grandchildren did get it, and they're very young, what is likely to be the lingering effects 1 month, 1 year, 5 years from now? Do we know yet?
Well, we do know that there's an unusual syndrome called post-acute COVID syndrome, PACS or PACS. We are studying this intensively, David, with cohort studies, because a certain percentage, and we don't know exactly what that percent is, but a certain percentage of people who have symptomatic disease, whether they've been hospitalized or not, have lingering symptoms for variable periods of time after the virus is cleared from the body. So they're no longer infected, but they have a constellation of signs and symptoms that are pretty consistent. And they are extreme fatigue, muscle ache, sleep disorder, temperature dysregulation, where they feel chilly or they feel they're not regulating their temperature properly. And some of them have something which is referred to as brain fog, which means they have a difficulty in focusing or concentrating. We do not know what the pathogenic mechanisms of this are or what it is that we can do about it, but it appears to be a real syndrome.
So speaking of the brain, I've been tested about 10 times, and they usually put a little stick up it goes to my brain, it seems. It goes all the way up. It touches the gray matter. Why is that the way that we have to test people? Isn't there a more pleasant way to get tested?
Well, originally, what people did was to get nasopharyngeal swabs, which is the one that you're referring to, where it feels like it's going through your eye into your brain.
Right.
That is not necessary. You can do a mid-turbinate swab, namely sticking it halfway up the nose and just doing that. And that is much, much less uncomfortable than the nasopharyngeal swab, but it's equally as accurate.
Okay. And let me ask you, early on, we weren't sure where this came from. And you and I had a conversation, I think at the Business Council about a year ago, where it was just beginning to come into the United States. And at that time, we weren't sure where it came from. Do you have any doubt that it came from a wet market in China, near Wuhan, or do you think it could have come from a lab in Wuhan?
Well, I'm not sure it came from a wet market, but I think it came from a jumping of a species from an animal reservoir, a bat or an intermittent species. There is a WHO group that has gone to China literally last week to try and see if they could get further information from the laboratory as to whether or not there was any possibility that it was a laboratory accident. But thus far, there's no data to indicate that that was the case.
Okay. So when the virus started hitting the United States, somebody said anybody that wants a test can get a test. That turned out not to be true. Why was it so difficult to get testing for everybody for quite a while?
Well, you might recall that we started off with a stumble, David, where the CDC's test, which they felt would be the test that people would be using, had a technical issue with it, which delayed the availability of testing for some time. And it was a delay before we got private industry involved, the regular laboratories that generally do our laboratory work, Quest and LabCorp and others. Finally, they got them involved, but still, we never really got to the point until recently where you really could get a test at any time you wanted. Right now, there's good news because the government is contracted with a company that makes a rapid point of care, sensitive and specific home test that you could get in a pharmacy and you could test yourself anytime you want. So the statement that you can get a test anytime you want to test will soon become a reality.
Okay. Some people who've been involved in the CRISPR technique have come up with their own testing mechanisms. Is CRISPR technique any better than any other tests that you're familiar with?
I don't think you necessarily need a CRISPR technology because the test is, it's a pretty simple PCR test for diagnosis and an antigen test for screening.
So originally you were a member of, and you still are a member of the White House Coronavirus Task Force. You could take us back. Initially, it was chaired by the Secretary of HHS, and then I think later by the Vice President. In the early days, how did it work? And were you comfortable that it was well organized and your involvement was being listened to?
Well, early on, it was, when we made the recommendation to essentially shut things down for 15 days, and then we extended it to 30 days, which I think was very important to kind of dampen a bit the spread. But the history of it, as we went on into the summer and into a very contentious, divisive year, there was less attention paid to the public health issues that I was involved with.
So when you were at the White House briefings, very often the president would say something and then you would get up and say something that wasn't quite what the president had said. Was that a little awkward from time to time?
Of course, it obviously was awkward that when you get up in front of, I don't know how many millions of people in a press conference and have to say something contrary to what the president said or to contradict him. I didn't take any great pleasure in that, but I felt I had to do it in order to maintain my integrity, as also to make sure the right message got out to the American public.
But from an interview that you've given, I think to the New York Times about this, you said the president never yelled at you and said, don't do this. He may not have been happy, but did he ever call you and say, don't say these things? Or he just basically wasn't happy and let other people let you know that?
No, there were times when he would let me know that he wasn't particularly happy.
Okay. So how has it changed now? President Biden, does he tell you what you're doing wrong, or does he contradict you, or how does it work now that's different than before?
Well, when President Biden came in very soon after his inauguration, he made a couple of things very clear to the medical team. He said it publicly, but he also said it to us privately. And it was, if I could paraphrase him, I think pretty accurately, he said, science is going to determine what we do. Science is going to rule. We're going to let evidence and data guide our decisions. We may make some mistakes and we may stumble. And if we do, rather than pointing fingers, let's just fix it. And that was really very refreshing to hear that science was going to be the determining factor about what we do in recommendations and guidelines and things like that.
Now, your involvement now is you are still a member of the equivalent, I guess, coronavirus task force. You're also the head of the Infectious Disease Institute at NIH, but you also have another role as a medical advisor to the president. Could you explain that?
Well, the medical advisor role really is essentially identical to my part of a team, a medical team that meets essentially one way or the other by Zoom every single day. We have a press conference 3 times a week. We've done that now over the past couple of weeks, where we bring out to the American public the relevant public health and scientific facts and answer questions from the press. So my role or designation as chief medical advisor to the president really is synonymous with my being a member of the medical team, which is made up of, Rochelle Walensky of the CDC and Vivek Murthy and Marcella Nunez-Smith and David Kessler and a whole bunch of people on that team.
Does the president of the United States, President Biden, ever say, I'd like to get on TV. I'd like to do the briefings myself. Does he ever say that to you yet?
No, he has not. He has not. I think remember when he was running for president, he said, when I become president, we're going to let the scientists do the talking. He made that very, very clear. So I don't think he has any interest in getting up and talking about these things from a political standpoint.
In hindsight, why do you think the president and some of his supporters thought that wearing a mask is a sign of something bad, weakness or whatever it would be? Why in hindsight do you think that was such a terrible thing to be seen wearing a mask?
David, I don't know the explanation of that. I really don't. Something personal about needing protection or what have you. I'd have to psychoanalyze that, and I don't think I can.
But at the time that you were doing some contradicting of the president, you needed security guards. Was that the most dangerous time of your life, other than when you're treating Ebola patients directly? But were you worried for your physical safety and your family's safety?
Well, I was until I got the security detail. So that makes it much less anxiety provoking. What happened is, as you know, the great divisiveness in this country. So when I began saying things that were purely public health statements and guidelines and recommendations, that there were some people, a fair number of people, I would imagine, in this country that was so against that they, became aggressive and threatened me, my life, my physical being, my wife and my children. It was really, really ridiculous and very, very unfortunate that there would be people that would be harassing your children and your wife because you're trying to get a public health message out there. That is really bizarre. Still can't figure out what that's all about.
To date, around 450,000 Americans have died as a result of the coronavirus. How accurate are these numbers? Sometimes people say that we count people differently than people in other countries when they die, or if they have some other disease, we count it as a COVID death. Is there any truth to that? Are these numbers about 450 accurate, do you think?
I think they're pretty much accurate, David, really. I mean, there may, people say, well, people die of other things and happen to have COVID, and you say they die of COVID. On the other hand, there very well may be people who die of COVID, but you don't recognize they die of COVID. I think it's a wash. I think that the numbers that you're seeing are pretty accurate. I would think they're really quite accurate.
And before this is over, let's say by the end of this year, hopefully, and you would expect everybody everybody that wants to be vaccinated, you think can be vaccinated by the end of this year?
I hope so, David. I'm less concerned about getting the vaccine to them than I am about vaccine hesitancy. I just would hope that those who are reluctant to get vaccinated or who are doing a wait and see approach where they want to make sure that a number of people get vaccinated before they come forward, I would hope that we could get at least 85% of the people in the country vaccinated. That's what I really would hope we could do.
For herd immunity, you have gone from sometimes saying 70 to 80% or maybe more than 80. What do you think we need for so-called herd immunity?
It's an estimate. I don't think anybody has a totally accurate or can't prove that they have an accurate number. I have estimated, based on our experience with measles, which is about 90% or more required for herd immunity, that somewhere between 70 and 85% of the population needs to be vaccinated to establish herd immunity. But that is purely an estimate. The only way you know if it's accurate is if you get to a certain level and you get no infections in the community. Then you get below a certain level and you start to see breakthrough infections. Then you know that that's about the level of herd immunity. We have experience with measles because we know that in a community, when you keep the level of vaccination above 92, 93%, that you really do have herd immunity. But in some communities that have gone down into the 80s or lower, we clearly have seen breakouts of measles in that community, which confirms that the level of herd immunity is probably somewhere about 90% or so for measles.
So if another pandemic, another disease were to jump from species from a bat, another type of bat, to the humans, are we better prepared for it than before? Do we have more medical equipment, more readiness to prepare to treat people, or are we basically where we were a year ago?
No, we clearly are much better prepared right now. One of the things that the science came through for us was that the previously unproven vaccine platforms, particularly the messenger RNA, which people had some skepticism and doubt over, was an overwhelming success in being able to rapidly adapt and make a vaccine for a relatively new, if not brand new, pathogen. Also, I think right now we're realizing some of the failings, the local public health systems that really did not respond adequately to the ability to identify, isolate, and contact trace So we kind of know now what the weaknesses are and what the failings are. It's up to us to begin to correct them.
Now, the countries which have done the best so far in getting their populations vaccinated are countries that have national health services like Israel. Do you think in hindsight, we'd be better to have a national vaccination process as opposed to state by state?
Well, the one thing that I think we could have done much better on, and I've recommended that we change that looking forward, and there will be much more emphasis on what I'm about to tell you in the Biden plan, is that months ago in the former administration, there was a very heavy emphasis on the federalist approach, where the states are independent, they can do things the way they want to do it, and the federal government keeps a bit of a hands-off on that. That works well for certain things. Otherwise, our founding fathers would not have established that. But the thing that it doesn't appear to work very well on is in the response to an infectious disease outbreak, because no matter what state you're in or what particular uniqueness you have in your state, infectious diseases don't know the borders of states. They don't know the difference between Louisiana and Mississippi or Mississippi and Alabama. So if you're going to have an adequate, or more than adequate, but an optimal response to an infectious disease outbreak, you have to do some things that are rather consistent. And you've got to have a good cooperation, collaboration, and hopefully synergy between the federal government and the states and the cities, which is not really what we had a few months ago.
By the way, did you ever worry that you could get COVID-19? You're the head of the infectious disease division or institute. Wouldn't it have been embarrassing if you'd gotten it? Did you try extra hard to make sure you didn't get it?
Well, I did what I was preaching to everybody else to do, to wear a mask, keep physical distance, avoid congregate settings, and wash your hands frequently. So I was practicing what I was preaching. I certainly did not like the idea of the possibility that I could get COVID-19. I mean, I would be a higher risk person because of my age.
For the Super Bowl, did you have a lot of friends over your house and things like that?
My wife, my best friend, she was the only one that was there.
So let's go back to, you grew up in New York, and you were a basketball player in high school, a star. Did you ever consider playing at Duke?
Not in my wildest imagination. I was a very good 5'7" point guard, but the days of the 5'7" point guards are over, particularly when you have an equally as talented 6'6" point guard.
Right. So what propelled you to go to medical school? Why did you decide you wanted to be a doctor? Your parents say you should be a doctor? Or, how did you get this desire to be a doctor?
I was more interested in the humanities early on, David, probably related to my multiple years of Jesuit training. Then when I was introduced to science and biology and chemistry and the sciences, I found that I really liked it a lot. So I was trying to figure out what's the best way to combine my interest in the humanities, which was generated by studying the classics and the Greek civilization, Latin, Romance languages, philosophy. I thought the best way to combine that would be a physician, where you could be very closely related to the human species, but you could also do science. So I put those together.
Okay, but why did you go into infectious diseases? After you got your medical degree, I think at Cornell then, and you came to NIH. You've headed the Allergy and Infectious Disease Division since 1984, but you were there before. Why did you pick that area, and what's the appeal of it to you to go in that area?
Well, there are so many exciting subspecialties in internal medicine. I picked infectious diseases. I came at it through the specialty of immunology. I got very interested in the body's immune response to pathogens. And that then led me into the field clinically of infectious diseases. I felt it was really very exciting. I mean, because infectious diseases, they are usually acute. You can prevent them, you can treat them, and they have global implications when there are outbreaks of infectious diseases. So historically, the field of infectious diseases is really quite exciting and impactful. I mean, diseases like measles have shaped civilizations, smallpox, the plague, very exciting field. And it's something you can do something about. You can prevent them, and many of them you could treat.
In the early 80s, you were dealing with AIDS before we knew that HIV could cause AIDS. Was that one of the most difficult times in your career when you were dealing with that problem, trying to come up with a solution, also dealing with people that were thinking we should do much more at the NIH than we were doing?
Well, the early years of HIV for me were some of the darkest years of my professional career and my life, because prior to that, I had been at the NIH from 1972 to 1981, and I had been fortunate enough to develop effective therapies for a number of autoinflammatory, autoimmune type diseases. So I had a very successful career at a very young age, and things were going very well. In 1981, when the first cases of what would turn out to be AIDS were recognized, I changed the direction of my career and focused solely on this brand new disease, which ultimately we would call AIDS, and which would ultimately be shown to be caused by HIV. The problem was, from 1981, for several years thereafter, virtually all of my patients died. So it was very, very difficult when you're trained to be a healer and you wind up healing no one because everyone is dying. And then after multiple years of that, with the development of effective drugs, it was an extraordinary transformation where people went from almost the inevitable death sentence to having literally being able to lead essentially a normal life because of the combination of drugs that were finally developed in the mid-90s.
So you talk about your patients, and you still have patients, but you're the head of the entire division. Why are you dealing with patients? Why don't you have other people deal with them and you can just run the division? Why are you still seeing patients?
Well, because I never really felt I wanted to give up my identity as a physician. I mean, you know, people, when they try and figure out who they are and what they are, yes, I direct a very large institute, and I'm very heavily involved in public health policy. But at my core, I'm a physician, and I will always be a physician. And that's the reason why I don't want to ever get too far removed from patients. And that's the reason why I still make rounds and I still see patients.
When you see patients today, do they want a selfie with you before they want treatment, or?
Well, some of them do, but I think we concentrate more on their health than on selfies.
So a few years ago, you had to deal with the Ebola crisis, and you had Ebola patients that you were treating yourself, and you had to get all kinds of equipment to do that. Weren't you risking your own life by treating an Ebola patient? Couldn't you have gotten some medical resident to do that?
Well, that was actually the exact reason why I did it, David. I really did not want to ask my staff to put themselves in harm's way in treating patients, because, as you know, healthcare providers were at considerable risk of getting infected. The risk was dramatically diminished because we had the proper personal protective equipment. But I didn't want to tell my staff to go ahead and do something that had any degree of danger that I was not willing to do myself. And for that reason, I just became part of the team that took care of the Ebola patients that we saw at the NIH.
Now, when history is written, one of the things you will be best remembered for, I suspect, will be PEPFAR. Can you tell people what PEPFAR is and how you were involved in it and are?
Well, PEPFAR stands for the President's Emergency Plan for AIDS Relief, and it really was, in many respects, the brainchild of President George W. Bush. When we began to develop and have very highly effective therapies for HIV, starting from 1996 up through 2000, 2001, when clearly we transformed in a positive way the lives of individuals who are HIV infected. One of the things that stood out was that people in the developing world, particularly in Southern Africa, did not have access to drugs, and they were dying at a very high rate at a time when those of us in the developed world were essentially, who were infected, were leading essentially normal lives. I was very struck by this. And when I visited Africa a few times, I felt that we really needed to do something about the fact that these individuals didn't have access to life-saving drugs or prevention or care. Simultaneous with that, President George W. Bush in 2002 realized that this was an issue and asked me to come and visit and then ultimately go to Africa to figure out, is there something that we could do that would be transforming for individuals who are either at risk for or who were infected with HIV? And his exact words were that we as a rich nation have a moral responsibility, because we are fortunate enough to have the resources, to make sure that those countries and those people who don't have the resources don't suffer and die from a disease merely because of where they were born. So he asked me to go down and see if we could put together a transforming program that could make life-saving drugs and prevention available. So I did. I came back. I told him a program could be done, but it would cost billions of dollars. He said, go ahead and put it together and let's see what we have. I wanted to be responsible and I wanted to be transforming. And I worked on it together with colleagues such as Mark Dybel and others. And after several months, we put it together. He accepted it, and we decided we would call it the President's Emergency Plan for AIDS Relief. Thus far, it has been responsible for saving about 14 million lives. So I think that's going to be an extraordinary legacy for a president of the United States.
When you turned 70, I came to see you and said, why don't you do something useful with your life like private equity? Why don't you come into the private equity world? You can invest in healthcare related things. And you said, I don't care about making money. I just want to help people. And I said, but nobody will ever hear of you if you just stay here. Did you ever have any regrets about not getting into private equity and retiring at 70 from the NIH?
No, David, I didn't. I don't and did not have any regrets. I remember very well your visit to my office. You were a bit surprised.
Well, a little bit, but now you're 10 years later. Are you slowing down any? I mean, you power walk a couple miles every day with your wife. You are fairly, a big workaholic. Are you slowing down any?
I don't think so. I mean, this year has been, I think I've worked harder this year, David, than I have ever done in my entire career. I mean, it's just the stress and the demands on time dating back to, January, February of 2020 up until the present time have been as intense as anything that I've ever been through.
So you intend to stay for the foreseeable future, as I understand, is that right? Doing what you're doing?
Yeah.
And do you get any vacation? When was the last time you had a vacation?
David, I'm not being facetious, but I don't even remember. It was so long ago.
Okay. Well, look, Tony, we are at the time that we told people we would finish, and I want to thank you for your coming today and honoring Duke, and also the Duke Global Health Institute. I also want to thank you for your service to the country over an enormous number of years. And if you ever change your mind on private equity, please give me a call, okay?
I will. Thank you.
All right. Thanks a lot. Bye.